This is the second session that describes pulmonary function tests. The learning objectives are to list the pulmonary function tests, define pulmonary ventilation, describe dynamic lung volumes and capacities, explain the importance and the significance of different lung volumes and capacities, explain the clinical importance of assessing lung volumes and capacities in different lung diseases. Pulmonary function tests are performed to examine the working ability and the physical fitness of the person. This is done by testing the efficiency of the respiratory system to move air in and out of the lungs. So, by doing the pulmonary function test, we're evaluating one or more major aspects of the respiratory system, such as the lung volumes, the airway function, the gas exchange. And these tests include the pulmonary ventilation test, the static lung volumes and capacities, dynamic lung volumes and capacities, the assessment of the regional ventilation perfusion ratio, blood gases and gas exchange test, the cardiopulmonary exercise test, metabolic measurement, and finally the chemical analysis of the exhaled breath. What are the indications of the pulmonary function test? Pulmonary function tests can be done to detect the disease, evaluate the extent and monitor the course of the disease, and evaluate the treatment. In today's session, we'll be discussing the dynamic lung volumes and capacities. To start with, let's define pulmonary ventilation. Ventilation is defined as the exchange of air between the atmosphere and the alveoli, where the air moves by bulk flow from the region of high pressure to the region of low pressure. Normally, the volume of the air entering the lung during a single inspiration is approximately equal to the volume leaving on the subsequent expiration. Certain pathological conditions affect the volume of the air contained in the lung or the rate of the airflow into or out of the lung. In order to gain information concerning the pulmonary function, the lung volumes, the lung capacities, and the airflow rates are measured. In this session, we'll describe the dynamic lung volumes and capacities. Dynamic lung volumes and capacities are tests measured in relation to time and expressed as volume per unit time. So the first dynamic lung volume is the respiratory minute volume, which represents the pulmonary ventilation. It's the volume of air inspired or expired per minute during rest. So its equation will be the tidal volume times the respiratory rate. So it will equal 0.5 liter times the range of the respiratory rate between 12 to 16. So the respiratory minute volume will ranges between 6 to 8 liter per minute. It's important to know that not all the air of the minute ventilation enter the gas exchange area of the lung where air is in proximity to the pulmonary blood. So we have part of the respiratory system where no gas exchange takes place. This is known as dead space. The ventilation of the dead space is said to be wasted ventilation. We have different types of dead space. If we take an example in a normal breath of 500 milliliter of air, only about 350 milliliter of air actually reach the alveoli where gas exchange occur. The remaining 150 milliliter of air, which represent 30% of the tidal volume in our example, fills the nose, the pharynx, trachea, bronchi, bronchioles, down to the respiratory bronchioles. The volume of these non-exchanging airways is known as the anatomical dead space. Dead space is not confined to the conducting airways alone. If some of the alveoli, for one reason or another, have little or no blood supply, the air inside them is not used for gas exchange, and this is referred as alveolar dead space. The sum of the two types of dead space is known as physiologic dead space. In normal individuals, the physiologic dead space is approximately the same as the anatomic dead space in well-perfused alveoli. Only in lung diseases, the physiologic dead space increases to exceed the anatomic dead space. And this is because the lung is unable to match the blood flow and the ventilation in various lung regions. Now it's time to discuss the second dynamic lung volume, which is the effective ventilation volume, which represents the alveolar ventilation. It's the volume of air sharing in gas exchange per minute during rest. That's to say, it will equal to tidal volume minus the volume of the dead space times the respiratory rate. So it will give us 500 milliliter minus the 150 milliliter of air times the range of the respiratory rate, which ranges between 12 to 16. This will give us the 350 milliliter of air times 12 to 16. So the effective ventilation volume will range between 4.2 to 5.6 liter per minute. Now it's time to ask an important question. What is the importance of the dead space? Dead space moistens and warms the inspired air, filters the inspired air, and protects the alveoli from the dust particle. Also, the dead space is responsible for the difference in composition between alveolar and expired air. To understand this, we have to know that at the end of an expiration, the conducting zone is full of old air. That's to say, air with less oxygen and more carbon dioxide than the atmospheric air, because it once occupied the alveoli where oxygen and carbon dioxide were exchanged with blood. On the next inspiration, that 150 milliliter of old air moves into the alveoli along with the 350 milliliter of fresh air, assuming that the tidal volume is 500 milliliter. Therefore, functionally, only 350 milliliter fresh air enters the alveoli with each breath. This volume of fresh air reaching the alveoli each minute is called alveolar ventilation. During expiration, the atmospheric air in the dead space, which is the 150 milliliter, is expired first. Then it is followed by the 350 milliliter of the alveolar air. Thus, the expired air is a mixture of both dead space air and alveolar air. That's why the partial pressure of the oxygen in the expired air is greater than that in the alveolar air, while the partial pressure of carbon dioxide in the expired air is less than that in the alveolar air. The significance of dead space volume, minute ventilation, and alveolar ventilation is described here. Subject A's breathing is rapid and shallow, while Subject B's breathing is normal, and Subject C's breathing is slow and deep. Each subject has the same total minute ventilation. That's to say, each is moving the same volume of total air in and out per minute and has the same dead space volume. But each has marked difference in alveolar ventilation. Subject A has no alveolar ventilation and would die in a matter of minutes, while Subject C has an alveolar ventilation greater than normal. We can see that increasing the depth of breathing is far more effective in elevating alveolar ventilation than increasing the frequency of breathing. This is important in exercise. A well-trained athlete can increase alveolar ventilation during light exercise with little or no increase in breathing frequency. Now coming to an important dynamic lung capacity, which is the maximum breathing capacity or the maximum voluntary ventilation. It's the maximum volume of air that can be respired in a minute by the deepest and the fastest breathing. Using the spirometer, the subject breathes as fast as possible for 15 seconds and multiply it by 4 to get the volume in 1 minute. The person breathes only for 15 seconds because he cannot breathe as fast and as deep as possible for a complete 1 minute to avoid muscle fatigue and the development of respiratory alkalosis. The normal range of the maximum breathing capacity is 80 to 160 liters per minute in adult male and 60 to 120 liters per minute in adult female. The maximum breathing capacity decreases with age. Factors affecting the maximum breathing capacity are the same factors affecting the vital capacity, but the measurement of the maximum breathing capacity is preferred because assessing the maximum breathing capacity includes the vital capacity as well as the power of the respiratory center and the respiratory muscles. Now coming to an important index, which is the Dyspnic Index. It's the percent of the breathing reserve to the maximum breathing capacity. The breathing reserve is the maximum breathing capacity minus the respiratory minute volume. So the Dyspnic Index is the percent of the breathing reserve to the maximum breathing capacity. Normally, the Dyspnic Index is more than 90%. If it is less than 70%, it indicates dyspnea, which is difficult breathing. And this means that this person is unfit. Another important parameter in the dynamic lung volumes and capacity is the forced vital capacity or the timed vital capacity. Vital capacity is the volume that can be expired following a maximum inspiration. The forced vital capacity, FVC, is the total volume of air that can be forcibly expired after a maximum inspiration, as shown in the graph. The volume of air that can be forcibly expired in the first second is called the FEV1. So, the volume of air that can be forcibly expired in the first second is called FEV1. Likewise, the cumulative volume expired in the second second is called FEV2. And the cumulative volume expired in the third second is called FEV3. Normally, the entire vital capacity can be forcibly expired in 3 seconds, so there is no need for FEV4. It's important to know that FEV1 is about 83% of the FVC, that's to say, about 2 liters is expired by the first second. And FEV3 is about 97% of the FVC, that's to say, about 3 liters is expired by the third second. So it's important to know that forced vital capacity and forced expiratory volume are useful indices of lung disease, especially the fraction of the vital capacity that can be expired in the first second. That's to say, the ratio of FEV1 to FVC can be used to differentiate among diseases. So in obstructive lung disease, the vital capacity may be reduced or may be normal but takes more time, while the forced expiratory volume of the first second will be greatly reduced due to difficult expiration, so the expired air volume during the first second will be decreased. While in the restrictive lung disease, both the forced vital capacity and the forced expiratory volume in the first second will be reduced. So the percent of the forced expiratory volume in the first second to the forced vital capacity could be normal or increased. It's important to know that forced vital capacity and forced expiratory volume are useful indices of lung disease, especially the fraction of the vital capacity that can be expired in the first second. That's to say, the FEV1 ratio to FVC can be used to differentiate among diseases. For example, in a normal person, the ratio of FEV1 to FVC is approximately 0.8, meaning that 80% of the vital capacity can be expired in the first second of forced expiration. In patients with obstructive lung disease such as asthma, both the FVC and FEV1 are decreased, but the FEV1 is decreased more than the FVC is. Thus, the ratio of FEV1 to FVC is also decreased, which is a typical picture of an airway obstruction with increased resistance to expiratory airflow. On the other hand, in patients with restrictive lung disease such as fibrosis, both the FVC and FEV1 are decreased. But the FEV1 is decreased less than the FVC is. Thus, in fibrosis, the ratio of FEV1 to FVC is actually increased, or sometimes it's normal. This is to emphasize on the fact that in obstructive and restrictive lung disease, both the FEV1 and FVC are reduced, but in obstructive lung disease, the ratio of FEV1 to FVC is decreased, while in the restrictive lung disease, the ratio of FEV1 to FVC is increased. So always remember that in obstructive lung disease such as asthma, the forced vital capacity is reduced or may be normal but takes more time, while the forced expiratory volume in the first second will be greatly reduced due to the difficult expiration, so the expired air volume during the first second will be decreased. On the other hand, in restrictive lung disease, both the forced vital capacity and the forced expiratory volume in the first second will be reduced. So the ratio or the percent of forced expiratory volume in the first second to the forced vital capacity will be increased or sometimes normal. Now coming to an important parameter of the pulmonary function test, which is the flow volume loop. The flow volume loop is generated by continuously recording the flow and the volume with an electronic spirometer during a forced vital capacity maneuver. The shape of the loop reflects the states of the lung volumes and airway throughout the respiratory cycle. Using the maximum respiratory effort, there are two loops. An inspiratory loop that starts from the residual volume till the total lung capacity, and an expiratory loop that reaches the maximum at first, which is called the peak expiratory flow rate, and then it declines. Looking at the flow volume loop, you'll notice that the inspiratory limb loop is symmetric and convex. The expiratory limb is linear. The airflow at the midpoint of the inspiratory capacity and the airflow at the midpoint of the expiratory capacity are often measured and compared. The maximum inspiratory airflow at 50% of vital capacity is greater than the maximum expiratory airflow at 50% of vital capacity. This is because of the dynamic compression of the airway during expiration. Looking at the flow volume loop in obstructive lung disease such as emphysema and asthma, you'll find that although all the airflow is diminished, the expiratory prolongation predominates, and the maximum expiratory airflow is less than the maximum inspiratory airflow. The peak expiratory flow sometimes is used to estimate the degree of airway obstruction, but it depends on the patient effort. Looking at the flow volume loop in restrictive lung disease such as interstitial lung disease, you will find that the loop is narrowed because of the diminished lung volume, and also the airflow is greater than normal at comparable lung volume, and this is because of the change in the elastic recoil of the lung that holds the airways open. What could be the clinical application of this session? One of the important clinical applications of this session is to know what is obstructive lung disease. In obstructive lung disease, people have shortness of breath due to difficulty exhaling all the air from the lungs. Because of the damage of the lung or the narrowing of the airway inside the lungs, the exhaled air comes out more slowly than normal. And at the end of the full expiration, an abnormal high amount of air may still be present inside the lung. The most common causes of obstructive lung disease include chronic obstructive pulmonary disease, COPD, which includes emphysema, chronic bronchitis, asthma, bronchiectasis, and cystic fibrosis. From this session, Now we know the importance of the two parameters, the forced vital capacity and forced expiratory volume in the first second, to diagnose the obstructive lung disease. Note that both the forced vital capacity and forced expiratory volume in the first second, both of them are reduced. But the reduction in the forced expiratory volume on the first second is much more than the reduction of the forced vital capacity. That's why the ratio of the forced expiratory volume in the first second to the forced vital capacity is reduced. And this is an important finding in obstructive lung disease. Another clinical application of this session is to know what is restrictive lung disease. People with restrictive lung disease cannot fully fill their lung with air, as their lungs are restricted from fully expanding. Restrictive lung disease most often results from a condition causing stiffness in the lung themselves. In other cases, the stiffness could be in the chest wall, or there is weak muscle or damaged nerve that may cause restriction in the lung expansion. Some conditions causing restrictive lung disease are interstitial lung disease such as idiopathic pulmonary fibrosis, sarcoidosis, obesity, including the obesity hypoventilation syndrome, scoliosis, neuromuscular disease such as muscular dystrophy. From this session, we know that the forced vital capacity and forced expiratory volume in the first second and the ratio between them are important parameters in diagnosis of restrictive lung disease. As in restrictive lung disease, you will find that the forced vital capacity and the forced expiratory volume in the first second both are reduced, but the reduction in the forced expiratory volume in the first second is less than the reduction in the forced vital capacity, so the ratio of the forced expiratory volume in the first second to the forced vital capacity may be increased or stayed normal. And this is an important parameter in the diagnosis of restrictive lung disease. By this, we finished the second session that describes the pulmonary function test. Hope that you enjoyed it. Thank you.